manifestations that lead to COPD. So what I talked about today, you're already there. You're already at COPD. It doesn't matter if it's emphysema, it doesn't matter if it's from chronic bronchitis. Because these are based on how did it affect their FEV1, how symptomatic are they, and what's their exacerbations like, okay? So that's why you don't hear those terms used. So I'm interested in, so you've had the exam, how did you feel the case discussions helped or didn't help, or it didn't make any difference whether we had done that or not?
Very beneficial.
I think it
I liked them.
Helped. Did anybody feel like they were fairly neutral? You cannot hurt my feelings. After 30 years of teaching. You cannot. So anybody was like, I don't like that part. You know, lectures are efficient. They're efficient for you. They're a lot of work for me. So I can tell you that on a handout, it's something that's new that I don't usually practice or know as well. It will take me between 30 and 40 hours to develop what you get. Okay? If I know it, then it'll be anywhere from 8 to 20 hours, somewhere along there.
After we leave the test and we all freak out and discuss things, I think the only question that some of us had was on the cromolyn use in pregnancy. What was the recommended medication?
What was the recommended medication?
Okay.
Still steroid. Some will go to cromolyn, but
Whenever you use cromolyn, though, isn't that for for pregnant women and then for exercise induced, or when is cromolyn indicated?
well, you'll see it as a second preferred in children. So it's just a secondary. If people won't take it, can't take it, a steroid, then you could think about cromolyn. And again, the reason why it usually isn't effective is because people just can't take it as much as they're supposed to. It's about 4 times a day is best. Some people can get by with twice a day, mild. So I started down the pathway of lectures. So lectures are efficient. I don't think they're always the best way to teach. I would prefer to do cases, but that also entails that you have done work before. So just watching you all, because usually when I teach PAs, I'm usually inserted about 6 months into where they have started and then go from there. And I've done most of them standalone. But in watching you all more from the beginning, it's workload. And so that's why I haven't gone as much in cases. To me, it is so boring to sit and listen to a lecture. And I can just see you all glaze over. I mean, you sit in class a long time. It's hard, and it's just like data dump. So I may introduce more cases as we go along, but right now I'll stick with
I have a suggestion, maybe like since we don't have enough time to kind of like prepare before to come to class to do the case studies or whatever, maybe if you just posted them and like a day later you posted the answers so we could like use it as a study tool to like make sure we're understanding like the treatment and stuff like that.
I will consider that.
Okay.
I will.
I was just going to say, I think the case studies are really helpful. We just weren't prepared for these last ones because of spring break. That was the thing. Most people, I can't speak for everybody.
You
I
can
didn't
say most
at all. And so showing up for the case studies, it was pointless for me personally. But on a normal basis, I think it would be helpful.
Some of it was a reaction is when I saw what Tiffany Crabb did, it's like, well, that's mostly what I'm going to say. So it made no sense for me to come in and do that again. So I knew that there would not be as much prep time. I didn't expect it. So no problem there. Yes?
Would case studies be an adjunct to handouts or in lieu of handouts? I really like handouts.
Yeah.
Or it wouldn't be in lieu of handouts. Okay. What I usually do, there's a teaching method called team-based learning. And so I kind of put you into teams, but it's where you would study before, and then we would come in and just do cases. So we might consider that at some point. To me, it's much more fun, I think. But what I find from students is that burden to you have to prepare. You have to look at stuff. that sometimes that becomes an overwhelming burden, or one that you're not used to. You're in a rhythm. I mean, you've probably grown up in this kind of education, so it's known. Anytime you introduce the unknown, it increases anxiety, and then it becomes, if it's not working, then it's my fault. So, so we'll see. We may use them and increase them as you go along. We'll see how the year unfolds. Okay. Any other? Someone else had a hand up.
Well, I was going to say, very similar to what you ended up saying, that I think this time the reason it was so helpful was because we had already heard it from the former lecturer. It was something that's brand new, though, unless we all actually study before. It would, I think it might be more, cause more anxiety than anything else.
It does put the onus on the student to prepare. Okay, anything else? Okay, let's talk about smoking cessation. When asked, most patients will tell you, my doctor, healthcare provider, whatever, has never told me I should quit smoking. Now that, and it's common, in more than 50% of patients will say that. I can believe that on some hands, and I cannot believe it on others. One, I can believe that it's either denial, or I couldn't absorb everything you were telling me, or actually, no one has ever told them that. Practitioners get weary. I find watching them over time is that the things that patients hardly will ever do, they just quit saying. I had a resident who he was only in his he was in his third year. And he said, I just don't talk about diet anymore because nobody will do it. Well, if you don't do it, even if patients don't do it, it's still important to say and do. I have watched, in just taking care of people over time, you're at mile marker 60, they're at mile marker 5. So bringing them along takes time and patience. So sometime if you're in family practice, you need to be much more like a coach. You're a physician, or a provider. You are the person who is prescribing and deciding therapy. But the other thing is that you have to kind of walk with people as they go. People can only do certain things. They also have a right to do whatever they want, to choose. So they may not choose to do what you have asked them to do, even if it was the very best thing for them. So often it just takes time for things to sink in with people, or them to come to grips with what they need to do. I worked in a lipid clinic at the VA for a number of years, and it was heavy diet. It was a pharmacist and a dietitian that worked with people who had lipid disorders and were being prescribed lipid-lowering therapy. We talked diet all the time. In the VA, very high-fat diet intake. It was nothing for them to go through a gallon of whole milk every 2 days. I had a guy who ate 18 eggs a day. So high-fat intake, you've got people coming off the farm. This is the way they were raised, high-fat. Fat is also cheap, so if you're coming out of raised in the 30s and the 40s, then you ate that because it was cheap and you could feed a big family with them. So we would talk about this every time. So one day I had a guy come in. I had seen him for over a year. He came in, his numbers were beautiful. I'm like, oh my gosh, what did you do? And he goes, well, I figured out it's what I'm eating that's raising my cholesterol. I'm like, duh, I don't even say that. But sometimes it just does not sink in, and they don't put it together with who they are. High cholesterol, yeah, that's other people. That was my cousin, so-and-so, but it isn't me. It didn't become personal. So, smoking is often like that. Also, the people who are most successful at quitting smoking are people who have done it a number of times. Usually first-time quitters are not that successful, but people who have quit multiple times, they tend to learn over time, and they get better at it. So never let someone who goes, I tried it, I just can't do it. You just have to keep encouraging. So smoking is really one of those that will test your patience, and also one that you are likely just to give up and go, I'm not even going to waste my breath here. In the 7 minutes I've got, I'm not going to spend even a minute on talking about smoking. So I'd encourage you to always keep that as part of your you're teaching. Okay, so a different handout. So nicotine's effects on the brain. It's addicting because it hits the pleasure centers of the brain. It increases dopamine release. So it makes us feel better. It decreases our anxiety, helps us to cope. Had a man one time that worked at Tinker, and when he quit smoking. And I said, what happened? He goes, I retired. He goes, I was so stressed. He was in accounting, I think. He said, I was so stressed all the time at work that this was my drug that helped me cope. And once I wasn't doing that anymore, I didn't need it. So he was able to put it down and walk away from it. So, if you've never smoked or you've never been around smokers, I think it's hard to appreciate how addicting this drug is. I'm so impressed the more I deal with people, the addiction potential of nicotine. So it causes a physical dependence. When we remove it, people have symptoms. That usually isn't the reason why people give up on cessation. The withdrawal symptoms from nicotine are usually, they can be intense, but they are usually short-lived. They last a few days, maybe a week or so. It's the psychological dependence, it's the dependence that the brain has also linked into what you do that makes it so addicting. We get very dependent on cues. Our brain does. How many of you drove to school today or walked and could tell me, I don't even remember doing that. My mind went to something else. Okay, so when we do stuff at a high level awareness, at high cortex, and we do it enough, the brain starts going, okay, got that, and moves it down to a lower level. So you can drive to work and never remember it. So I'd encourage you, go home a different way. You will notice that your alertness goes up because you have removed all those cues that the brain is used to you using, so it can say, okay, I know exactly where to go because I've seen this before. You go a different way and it's like, I haven't seen this before, you will pay more attention. So often when you're dealing with people who are trying to stop a behavior, and smoking is very much a behavior, you have to start uncoupling those things. So when do people usually smoke? What do they link it to?
Stress.
Stress, what else? Alcohol, go to the bar, you smoke, right? What else?
Take a break at work.
Taking a break, and what? And who are you usually breaking with? Your friends, yes. So when I had a friend who quit smoking, she said, it changed my social life because at work, that's when I got to talk to all my friends, but when I stopped smoking, I didn't go out with them because I'd be tempted. So that's a very real thing. What else? When else do people smoke?
After meals.
After meals? Yes. Okay. So you finish that cup of coffee in the morning and your breakfast, first thing you do is light up. Okay. When else do people smoke?
Before bed.
For bed? Okay.
When they drive.
When they drive? Okay.
When they're bored.
Yes, often when they're bored. They're bored. So when you're dealing with a smoker, that is one of the big things to identify. When do you smoke? When do you smoke? And then you have to start helping them figure out, how do I uncouple those things? It can be as simple as, in the morning, I ask them, where do you have your cigarette? So they'll describe their kitchen for me. And so I will tell them things like, buy a new cup. Buy a new cup, sit in a different place at the table. It just tells the brain, okay, it's different. When I do this, I don't smoke. She doesn't smoke, or he doesn't smoke. Boy, the car is a tough place to get people to not smoke. One thing is to get them to, get it cleaned out and remove that smoke smell. Helps a lot. Talking to people about the stress and how to manage the stress is huge. Number one is that if somebody is really serious about quitting smoking, you need to get them into a behavioral modification class. There's all kinds of classes like that. People who are the most successful, outside of those who quit cold turkey, people who are the most successful are those who do behavior modification plus some type of drug to help with the withdrawal symptoms. Okay. So, you can just hear in listening to me that it takes a lot of time. It's mostly problem solving. How are you gonna do this? What are you gonna do in this circumstance? When are you gonna quit setting a quit date? All of these are things that need to be worked through. People who do them are more successful. So get them into a behavioral modification program. Okay, so that kind of hit a lot of the things on page 3. Looking at event, situation, management of stress, anger, anxiety. Number one thing that usually derails people after they have quit smoking is usually a stressful event that they didn't anticipate and have no other way to cope, or this was their immediate go-to. It usually takes 6 months of a behavior change before it becomes rooted in. So think about something you've picked up in the last year. You've decided, I'm going to change whatever. I'm going to exercise more, I'm going to diet, I'm not going to eat this. And think about where were you successful, where were you not. If people can do something for 6 months, it becomes an ingrained habit. They don't have to think about it as much. It's so practiced that it's part of what they do. Less than that is usually a more vulnerable time when people will abandon it for old behaviors. Not always, these are general statements. Okay, so general approach there at the bottom is the 5 A's. So know these, they're fairly common in when you're talking about smoking cessation in the literature, and they're a good kind of prompt. So number 1 is always ask, do you smoke? Or have your nurse or somebody so that you know that what their smoking status is. Advise them to quit. A lot of people in surveys will say simply the fact that my doctor told me to quit, I quit. Okay? So you carry a lot of weight and a lot of power because you're in a health setting. And they're going to listen. They will listen to you. They may not do it, but they will listen. So advise them. Assess their willingness to quit. So I'll usually ask people, if you're smoking, then I'll ask them, well, are you thinking about quitting? When are you planning? What do you think you'll do about this? So that time it starts to give you at what level or stage of behavior change they are in. And where they fall can kind of guide as to what you do. Assisting in a quit attempt, people who are really close to the time where they are ready to quit. They're planning, they're in a planning stage. Those are usually people that are most ripe, that you can get into a program or help them get the medication. Always follow up, always follow up. Usually the most recidivism is going to be in that first 4 weeks. The other thing is that it's really good time to help them with problem solving. So they come in and they go, okay, I did really well, except one day I smoked. Well, what happened that day? That's where you can open that dialogue and you can talk to them about what will you do the next time that happens. Let them be the problem solvers. You are just the facilitator and the guide to getting them to quit. Behavior modification therapy offered everybody. Usually multiple formats help. So whether it's individual, if they've got something to read or something to view, those are the most helpful. Even telephone calls are helpful. Usually brochures are not that helpful. There is a quit line in Oklahoma, and I put the number down there, 1-800-QUIT-NOW. You can give it to your patients and call. They have counselors. They will give them medication for free. They can get the patches for free. This is part of the TSET settlement grant. And it's very good. I've had a lot of patients use it. I wouldn't say they're all successful. It's even a high number, but it is it's just one of the other aids to help. And so I would highly advise it. The other is that they need to tell people. That's one of the last things you kind of, as patients are moving towards a quit date, is they need to advise the people around them, their family, friends, because it's an accountability, The other is, it's letting your smoke friends at work know, I can't go out and smoke with you anymore. Or when I come to your house, if you could not smoke around me, or if anything where the smoking was tied to a social situation, it helps with those two. And hopefully they'll also support. The toughest is when a couple, if one tries to quit and the other continues to smoke. That is a difficult situation. So working with both of them is very helpful. I would always advise pharmacologic therapy, except in these situations. Sometimes people can quit cold turkey and they are usually the most successful. They usually also are the least addictive, if you read about smoking addiction. So if they can quit cold turkey, fine, that's great. They usually are more successful and they'll stay quit longer. But most people will need some kind, or will desire some type of aid to do that. So kind of the mainstay is nicotine replacement therapy. That's on the bottom of page 4. There's several forms, you're probably familiar with them. There's gums, there's lozenges, patches. Those are all over the counter and can be, people can get them. As long as they're above the age of 18, they can get them, purchase them, and use them. What I always find funny is they have them up front by the tobacco at the front of like Walgreens or CVS. So those are available. If you are dealing with adolescents, teenagers, you will have to give them a prescription for those products. There's 2 other products. There's a nasal spray, and there is also an inhaler that has nicotine in it. Those are prescription. And we'll look at those in just a second. So if you'll look on page 5, here's the gums. The lozenges are very similar. They need a little bit of patient education to go along with them, and you need to have some idea of how much they smoke. So a heavy smoker is considered a half a pack a day or more. So a half a pack is 10 cigarettes. So if you smoke 10 or more a day, you're considered a heavy smoker. So with the gum, the gum is a nicotine that's in a resin, a polyacrylic resin. And it has to be chewed in order to release that nicotine from the matrix. So the dosing is based on how many cigarettes they need a day, or they smoke a day. So if they smoke their first cigarette within 30 minutes, people who are most addicted, some of them smoke before they get out of bed. So if they have to smoke very quickly after getting up, because see, they've gone, maybe 6 to 8 hours without a cigarette, then you can use the 4 milligram, or if they're more than 10 cigarettes a day, you go with the higher. If they can get up, move around, and not need a cigarette right away, then you can go with the lower strength. Oh, this is less than 25. Okay, so 20 is a pack. Sorry. So less than 25 a day is the 2 milligram, more than 25 is the 4. This is what I do with the gum, is when people are going to start or have set a date and they're going to quit, then I put them on a regular schedule of the gum. The reason why is that the nicotine, so when people smoke, that nicotine gets into the bloodstream and gets into the brain very quickly. Nicotine can cross the blood-brain barrier with no problem. So they get a very quick onset, and they get a very high level right off the bat. All these other products is going to be very much slower and very lower amount of nicotine. That's why sometimes they can't stop smoking, because they can't get enough nicotine out of the products. So originally the gum was just meant to, whenever you have a craving, chew a piece of gum. It usually doesn't work because the release is slow and it takes about 30 minutes. I don't know how fast you can smoke a cigarette. I don't know, 5, 6, 7 minutes, something like that. So these take a whole lot longer. So I usually put them on a regular schedule, just listening to them and how they smoke. I also tell them if they're going to go into a situation where they were likely to smoke, to chew a piece of gum then. And then as they go down, then I move them to more of a PRN, but usually I put them on a schedule to begin with. The limit is less than 24 pieces a day. On the next page is proper chewing technique. So, and this is important, the lozenge isn't so much a problem with this, but the gum is. So the gum is in that matrix, it has to be chewed to release the nicotine, and then it has a real peppery taste, and it's not very pleasant. So when that taste begins to occur, then you advise the patient to park it. So they chew it, and then they park the gum in there, usually between their cheek and their gum. And they do that until that taste kind of goes down, and then they bring it back out and chew it again. That technique is really important to get the full use out of the gum. Avoiding food and drink 15 minutes before or during is important. You don't want to swallow it. Treatment recommendation is 12 weeks, but a lot of people continue to use it for a number of months, even years. I don't know of any recommendations not to do that. The lozenge is very similar, it's just not as technique dependent. It's easier to use, more nicotine gets delivered. The one thing is not to swallow it. Page 7, the recommendation is to use at least 9 lozenges a day. Saying avoiding food or drink before or after is important. Not to use more than 5 lozenges in 6 hours or 20 in a day. It's the amount of nicotine. So nicotine is really upsetting to the stomach. Swallowing a lot of it, overusing it can make people sick to their stomach, vomit. It also causes the hiccups. I don't know why. I'm sure it has something to do with the phrenic nerve that goes into the diaphragm. I don't know. But hiccups are very, very common side effect. Again, it takes about 20 or 30 minutes for it to dissolve. So those are your short, more rapid acting. The patch is a long-term delivery system. And they come in different strengths. Usually people start at the highest strength and then they step down over a period of weeks, usually through about 3 dosing different intervals. So the patch, it's usually designed to be worn 24 hours and then take it off. Usually what I tell folks to do is to put it on first thing in the morning. If they have nightmares, if they have side effects overnight, they can't sleep, then I have them take it off before they go to bed. Especially if you've got people who get up in the middle of the night and smoke, then I tell them usually keep the patch on overnight. But for a lot of people, I'll tell them to take it off before they go to bed. Questions about the patch? The major problem with it, besides the insomnia, is just the irritation from the wearing the patch. So moving it around is important. Questions? Yes, Brenda.
So are you still getting the blood pressure effects and everything from the nicotine?
Not as much. It probably only delivers about 30% of what you get out of a cigarette. So not as much. Nicotine effects are much lower on heart. You'll see that only when you've got people who've got unstable angina or they've had a recent MI or they've got serious arrhythmias do you actually have a contraindication. So you can even use it in people who have stable angina. Smoking and using these products together, though, way increases the amount of nicotine, should be avoided. People have had heart attacks doing that during those time periods. The 2 prescription items are the spray and the inhaler. I'll tell you, in all the time that I've done smoking cessation, I've had very few people who would elect to use these or who we've started it and they've continued it. There are a couple of places, I think, for them. For that nasal spray, it delivers the highest amount of nicotine of any of the products. It's much more similar to smoking. So for people who are most addicted or heaviest, ladies, you'll need to communicate?
No, I'm sorry.
Okay, so for those folks, I will talk to them about the spray. Otherwise, I don't use it very often. It delivers a high dose of nicotine. It's very irritating to nasal passages. People who have rhinitis or allergic rhinitis or other, even asthma, I don't tend to use it. But it is out there, and just keep it as a reminder that it is an available dosage form. The inhaler is on the next page. I think this is a cool device, but I'll tell you, most of the smokers I start on it never keep with it. A lot of patients miss that hand-to-mouth motion, or they have an oral fixation, they just can't stand to not have something in their mouth. Sometimes I'll suggest that the gum, or also straws, buy a box of straws and keep that in your mouth, and it seems to satisfy some of those cravings. The inhaler is an ampule of nicotine that fits in a device that looks like a Swisher Sweet, looks like a cigar to me. They put that nicotine ampule in there. When they push the inhaler together, it pops it, and then it will deliver about 4 milligrams of nicotine. And then they inhale it. So it's just like smoking a small cigar, I think. It requires a vigorous puffing, and they usually need to use about, I think it says 6 to 16 a day. What I find is that most patients find it too much work. I think that it takes about 20 to 30 minutes of puffing on it, and a cigarette is much less work. So I don't find very many people who like it, but I usually offer it, especially for people who go, man, I just miss that. I miss having that cigarette in my mouth. So those are the nicotine replacement products. There are some non-nicotine replacement products which you probably are familiar with because they've got commercials on TV all over the place. Chantix is one of them. It's a very good drug. It works on the nicotine receptors. But it does have some warnings with it. It has been associated with increased suicidal ideations in people who have depression that is not well controlled, or who have had attempted suicides in the past, or people who have unstable psychiatric illnesses that are not well controlled. So be careful with patients that fall into that category. Also cardiovascular, it has a warning listed with it in terms of increasing the risk of cardiovascular events for people who, I don't know that they had a baseline. It says increased risk of non-fatal MIs and the need for coronary revascularization or stents. This one and bupropion, patients start before they quit. So the thought is that you overlap them because it takes the drugs about a week to reach their maximum impact. So what they do is the patient sets a quit date, and then they start the drug 7 days before. With Chantix, they recommend that if at 12 weeks the patient has made no effort or has not been able to stop smoking, they recommend actually just stopping the drug and then restarting it at a different time or using something different. You can use it in combination with nicotine patches, and those have been found to be very potent smoking cessation treatment. Top of page 11, side effects, nausea, insomnia, abnormal dreams. So here, with this one and also bupropion, dosing it away from bedtime is important for both of those because they can cause insomnia. And the dreams they will usually describe as extremely vivid, very colorful. Sometimes they can be also very horrific. Nightmarish. So asking about those kinds of dreams, and usually they're very different from their normal dreams. Yes?
So when would it be appropriate to prescribe this instead of suggest nicotine products?
I would probably never, I would always use a nicotine replacement product. I'd probably look at combination. I think it goes to patients, what they want. Often you will find they've already tried stuff, and they'll tell you, I won't take this, I won't take this didn't work. And if they say it doesn't work, I would explore how did you use it, and I would see if there was a way to kind of recapture that type of therapy. But a lot of this goes to, if there are no contraindication, it would go to patient preference. Zyban is the marketed name for bupropion that has been approved for smoking cessation. Wellbutrin is an antidepressant, they're the same drug. Again, these are also where you begin a week or two with this one before the quit date, can be used with or without nicotine replacement. Notice though that there are some patients you shouldn't use it in. This drug lowers the seizure threshold, so they recommend it not be used in people that are being treated for epilepsy. They've even in the past said not to use it with glucose lowering agents because with hypoglycemia you can have seizures. That one I think is a much looser, and it would really depend on the patient. I wouldn't avoid it in diabetics. I've used it in quite a few of them, as long as their blood sugars are fairly well controlled. The type 2s don't tend to be as susceptible to having low enough lows that they would have seizures. Or the use of a monoamine oxidase inhibitor in the past 2 weeks. Yes, Larry?
Just real quick, are these prescriptions going to be covered by insurance? Because they look rather expensive.
Yes, yes, most of the time they're covered. But what you'll find is that if they've done it, let's say they've used Chantix in the past year, if they are looking for a second, they may not. Or they may only pay for so many courses of them in a period of time. That's the only thing I have run into. Now, the over-the-counter nicotine replacement products, those are usually not covered. They're over-the-counter. Medicaid will cover them, or they can get them through the QUIT program. So some of it will depend. Selecting therapy, so choosing first-line therapy, always have them in behavior modification. They may reject it, but you should talk to them about the value of it. So nicotine replacement, again, it's experienced with the product. Again, Larry brought up insurance cost or considerations. Second line, there are several second line agents. I only put one down that has been shown to be effective, and that's nortriptyline. There's also been, people have looked at clonidine and the SSRI antidepressants, but nortriptyline is the only one that has some data with it. You don't want to use it in people who have arrhythmias or cardiac conduction abnormalities that can worsen those. So mostly what I want you to focus on are those first-line therapies. But be aware there are some other things out there. Combination therapy, again, you can combine a patch with a short-acting. So a patch and then have them with gum or a lozenge for breakthroughs or for cravings. Or periods of time where they find the patch is not enough, or bupropion and a nicotine or Chantix and a nicotine patch. You do not want to use, I wouldn't use Chantix with a short acting. The nicotine amount is probably too high and put them at risk. Special populations. Light smokers, there's not as much data out there about which to choose or how to choose therapy. A patch seems to be good on some of them, even starting with a lower dose patch instead of the higher dose because they're not as used to as much nicotine. For breastfeeding women, the data is not real conclusive. One is that you absolutely want them to quit and encourage them to quit as early as possible. And if they can quit without using the nicotine replacement products, that's recommended. But the amount of nicotine they're going to get from the product versus from smoking is quite a bit less. Bupropion, it's recommended not be used in the first trimester. I don't think I couldn't find data on Chantix. I probably wouldn't recommend that one. But the nicotine replacement products, yes. Psychiatric illness, we've covered, it's just more, it's summarized there for you. For smokeless tobacco users, I don't have any data for you on what product to recommend for them. But again, encouraging them to quit is important. For cardiovascular disease, usually you're looking, if people are stable, they usually can't tolerate any of these products. If they are unstable though, they've got angina that is progressing or not well controlled, if they've had a heart attack in the last 2 weeks, if they have a serious arrhythmia that may not be under good control or is aggravated by certain triggers, then you would probably want to avoid those products. Bupropion, safe, effective for patients with stable cardiovascular disease. In Chantix, we've talked about the increased risk. So it probably wouldn't be the first one you would go to. You would look at the other products. For kids, for adolescents, nicotine patch or gum have been shown to be effective or safe for them. Weight gain. Weight gain will occur, and I would encourage you just to be honest about it. The average is 10 to 30 pounds. I find this is hardest in women. The men, they'll go, yep, quit, I gained weight. I don't seem to get the angst in them, but women, I've had a lot of women go back to smoking because it's so effective in controlling their weight. So being honest about it, recognizing it, healthy diet, exercise, all of that. It's almost unavoidable, but you can certainly give them outlets and ways to address it. Again, the food's going to taste better, it's going to smell better. Hospitalized patients. What an opportunity. Most hospitals are smoke-free now, so this is a time when patients are undergone an acute illness. You can certainly start these products in the hospital, unless there's a contraindication. And then following up with them post-hospitalization is going to be really important. If they're interested and they are accepting of therapy. I gave you on the next page, I like this. This is a poster that at the time that I put it in you could get. I gave you the website, but I like it because you could put it in your office and it shows you that the longer you don't smoke, all the benefits you get. So many of the things that you're at risk for go away over time and can even approach non-smoker status. So that's really encouraging. I even tell people, even up to the end, that it is not too late and you can still get benefits. A lot of times, heavy smokers, long-term smokers, COPDers, they'll just tell you it ain't gonna matter. But it does matter, and it can have health benefits for them whenever they stop. The last 2 pages I summarized in a chart for you the different products. There's nothing new in this table. It's simply, if it's an easier guide for you to study, please use it. I'm not going to ask you doses, except on the gums and the lozenges, I will ask you amounts. Like, I'll give you a scenario. Patient smokes this amount. Which strength should you choose? Okay. But I'm not going to have you memorize all the patches and stuff. It's good enough to know at this point is that there's usually 3 patch level or 3 dosing levels for each of the patches. And it's a step downward titration in treatment using those.
Do you want us to know like how many pieces of gum per day? Or
Yes,
okay.
I do want you to know those in terms of treatment
Okay.
or in terms of the amount you should not
Okay.
exceed. Okay, questions about these? Okay, a lot of material. I appreciate your attention, and I will see you, I think, Monday for pneumonia. So have a happy Easter, a good weekend, and I'll see you next week.